We will now have both doctors up on stage to have a Q&A segment. As always, if you have any questions, please scan the QR code on the screen to submit them. Or if you want, we can also have some mics on standby to address your questions. Anyone has any burning questions to start off? If not, we will have a list of questions from Slido, and I do have one here for our doctors. When it comes to treatments like surgery or radiation, how do we balance cancer control with potential side effects like urinary or sexual function?
Yeah, I think everyone has a different approach. And at the same time, every patient has different needs. For example, we see men who are not worried about erectile function, but are more concerned about incontinence and all that. And we also take into account, how well is this patient? What are his other medical issues? What we think his life expectancy is going to be like. So generally, in a younger age group, I do tend to counsel towards surgery because in terms of side effects, if we pick up early, we normally can deal with the erectile function. Incontinence now, more and more so, is less of an issue because of our new techniques. But importantly, we then don't have to deal with the potential long-term side effects of radiation. So younger people, I will tend towards surgery. People with limited life expectancy, I will tend to advise for radiation. There is another group of people who, even though we pick up cancer, for example, if they are low risk, we may choose not to do anything. And also another group where really when the life expectancy is shortened or very short, we may choose actually not to do anything and then treat symptomatically as they come along.
I agree with all the points touched. In fact, the bias of selecting treatment based on age is should not be practiced routinely, but I agree because of the profile of side effects. Either you try something that has short concern that likely to recover and improve with time, or you try something that doesn't cause any long-term harm.
Okay, our next question. Do sudden or occasional blood in urine or semen means that it has a high chance of prostate cancer?
Okay, I'll start. Okay, so blood in the urine, blood in the semen are two different situations. Blood in the urine, actually we're more concerned about other things. For example, kidney issues. We're talking about, in terms of cancer, maybe kidney cancer, stones. We're worried about bladder cancers, especially if they're a chronic smoker. Blood in the semen, yes, can be related to prostate cancer, but more likely it's going to be inflammatory in nature and all that. Saying that, please see a doctor and get a proper checkup. Yeah.
I think other point is most common symptoms that we hear from prostate cancer patient is problem with urine flow, not blood actually. There was one case that I heard of in the past 5 years where he has new erectile dysfunction. That's because he has very bulky cancer. But beyond that, the most common is urinary flow issue.
Yeah, I think I agree. It's the thing to remember is that you don't have to have a big prostate to have cancer. At the same time, you have a big prostate doesn't mean you have cancer either. But they can overlap. So a bit like a Venn diagram where things can overlap here and there. Yeah. Sorry, I think there's some local, some of the guests.
Oh,
yeah.
Yes. Who would like to have a question? Okay.
Thank you, doctors. My question is a bit general. As many times mentioned other places, that hereditary conditions are, there are much higher chances of passing on. In that case, are these exclusive, or there is a possibility of, if there is a blood cancer or throat cancer, that can result in some other form of cancer in the family?
Maybe I'll let Dr. Wong talk about, the hereditary cancers, because I think that's his area.
So we talk about genetic testing to identify patients with possible DNA repair defects. So that comes into overlapping information. The clusters that's most well understood is actually the same cluster as breast cancer, the BRCA clusters. So the cancer in those clusters, breast cancer, pancreas, prostate, those are the big three, sometimes ovarian. So if we have these, it's usually picked up using genetic tests. We have to undergo proper genetic counseling prior to testing and after testing. Throat cancer typically is smoking-related cancer. We do not see it as a proper cluster with prostate. Yeah.
Okay, our next question is the TULSA method approved and done in Singapore?
Sorry, what?
TULSA.
Oh, TULSA is
TULSA,
not.
yes.
TULSA is not available in Singapore. I think it may be available in Japan. I think that's probably the closest location. So this is a kind of like focal therapy for the prostate. So it can be used to treat the whole prostate or specific zones. Usually we're talking about using it for specific zones. It has the same, so there are many energy sources you can use to kill tissue. You can either use cold, that means freeze it. You can use heat, that means cook it. And basically, TULSA is a way of applying heat to the prostate or the area that is abnormal. So it has the same incidence of recurrence, about 20%. So it's like any other focal therapy. You just choose which modality you want.
Okay, I think we have time for one more question from the floor. Is there anyone? Okay, this.
If a person has had prostatectomy, the successful surgery, after that, would a yearly PSA test be sufficient to monitor that there's no recurrence?
Okay, so yes, usually if it's a successful surgery, we often look at a few things. That means about 6 weeks to 8 weeks post-surgery where the PSA is. That gives us the baseline. We look at what is the tissue sample that comes back. Are the margins involved, not involved? And then we trend the PSA over a couple of years. So yes, I have quite a few patients I see yearly for PSA, or sometimes even every 2 years because they just want to follow up after 5 years. Yeah, so generally I think a PSA is good enough test. We also generally do a basic examination also for these people.
Okay, thank you so much. I think that's all the time we have for today. For those who have submitted slider questions, not to worry, we'll address them at a later time. Thank you so much, doctors.